Yes. 3, 2, 1. Everyone is here. Thank you very much. Good evening, everyone. It's our pleasure today to invite a group of experts, worldwide experts. I have to thank all of them, but first of all, I have to thank Dr. Baran Tokar, the president of the Turkish Society of Pediatric Urology, and also the Dr. Ahsan, the secretary of the Turkish Society of Pediatric Urology. We have the panel of experts, all known, Professor Alaa Ghoneimi, the president of the European Society of Pediatric Urology, Professor Amine, the head of the Arab Society of Pediatric Surgery, Professor Muhammad Arshad, the president of the Pakistani Society of Pediatric Surgery, and Professor Ghulam, the president of the Pakistani Society of Pediatric Urology, and Professor Mingle from India, the president of the Indian Society. So, hello, we can start on, please, Baran, with the first one.
Okay, welcome to everyone. It's a really great pleasure for us to make the second conjoint meeting of Turkish Society of Pediatric Urology and IPEG Middle East chapter. We are very glad to do it again, and we have now in this webinar 4 panels and 4 cases we're going to discuss, and there are distinguished faculties for presentation, also for discussion, and at the end of each panel we are going to make a brief conclusion and also get your question from the chat box. So I would like to pass it to Dr. Amine Kasai for the first panel because time is really valuable. Okay, Amine, please go on.
Thank you so much, Baran. Welcome, everybody. I want to thank also IPEG Middle East and the Turkish Association of Pediatric Society of Pediatric Urology for the great efforts to make this webinar successful, and particularly my dear friend Baran and my dear friend Dr. Ahsan. So we'll begin by the first case that will be presented by Dr. Ghulam Zafar from Pakistan. The name of the case is vesicoureteral reflux when treatment leads to obstruction. Oh, very nice title. This case will be discussed by 2 eminent experts, my dear friends, Professor Singh Miglani from India and Dr. Baran Tokar from Turkey, and it will be concluded, though, so the wisdom words would be to Dr. Sabine Zundel from Switzerland. So without any delay, we will begin by the first case, and we will have 20 minutes for the presentation and also for the discussion.
Everybody can see my slides?
Yes.
Yes, sir. Okay. Assalamu alaikum and good evening, good morning, whatever, where is everybody. Thank you very much for giving me the opportunity. I have no disclosure. My case is 12 years old boy, 31 kg weighing. He was diagnosed a case of grade 5 left side VUR at the age of 3 years, 2015. At that time, here you can see his MCG, initially MCG showing the left side grade 5 VUR, and the DMSA at that time showing 37% differential function. He underwent left ureteric reimplantation by lead-better pellet technique. He remained well and asymptomatic, but he presented again in 2022, 9 years after the first reimplant, with left flank pain, fever, and there was gross hydronephroureter with pyonephrosis. Initially, we managed the patient with putting a catheter in and starting IV antibiotic, but it does not settle. So we have to place the PCN on the left side. And the first thing we did after the patient stabilized and fever-free, and we did MCUG, which shows no reflux, and there was smooth bladder. Here, this is the MCUG showing smooth bladder and urethra. At the same time, we get left antegrade nephrostogram, which show the left obstructed megaureter. There's a dilated torture ureter. So, keeping in mind this is obstruction after the reimplant, we decided to treat it by endoscopic way, and we did cystoscopy and did endoutotomy. And when we did cystoscopy, we found there was very large submucosal tunnel that was about 12 to 13 centimeter. And here you can see, this is the new orifice of reimplanted ureter, and this is a large tunnel almost reaching across the right lateral wall. And we open this ureter over the guide wire with colon knife to make the tunnel shorten. Because they were 12 to 13 centimeter, we almost opened 5 to 6 centimeter tunnel to bring to this orifice in the midline to make the submucosal shorter, and then put double J stent. And we kept this double J, this ureter was open almost. So we kept this double J stent for 3 months, and after 3 months, the double J stent was removed. Over to you, Dr. Amine.
Yeah, we will listen to our experts.
Dr. Zafar.
Yeah.
And the ureterotomy that you made, it's such a long tunnel is very, very unusual in any reimplant, 12 to 13 centimeters, but he must have been done somewhere else. Yeah. And you opened from the lower part, which was stenotic, or from the upper, middle up to the lower part? I was not very sure about that.
No, we opened the distal part.
Distal part.
Yeah, distal half, we opened the distal half.
Okay. So what was the result?
So may I talk, or are you going to continue to Dr. Miglani? Or?
No, please carry on.
Yeah.
Just speak.
I think we have to think and evaluate this patient in 3 phases. Firstly, I would like to ask to Dr. Zafar why there's a long gap between the operation and the second admission. I think 9 years something. I mean,
it is 7 years actually, but I think it's miscalculated. It's 9 years. From 15 to 22 is 7 years.
Yeah, almost 7 years. Anyway, I mean, it's a long period. So to understand whether it's a early postoperative complication or long-term complication, so we have to accept that this patient has this pathology maybe since the last 7 years. If this symptoms and the findings appear at the last year, then it's a long period of time. So firstly, if I see in the second admission, if I see this kind of patient, I think just before the differential diagnosis, we have to just concentrate on the pyonephrosis. I mean, this is important, and we have to just drain the urine and also treat the UTI. So that's important. So I agree with you, and double G cannot work in such patients. So percutaneous nephrostomy you just perform. So that's good. And in the second phase of the management, we have to consider the voiding stereotogram and also antegrade pyrography. And you don't have any reflux at this position. But during the antegrade study, what I saw in your graphs at the right side, at the corner and corner, there's a bird's peaks appearance and very sharp cutting pinpoint sharp ending of the ureter. So that's especially important to decide whether we can just do something minimally invasively, or we have to just consider the definitive surgery. So this appearance on the graph show me that this patient needs a definitive surgery. I mean, we have to just operate again, reduce surgery needed. So following these phases, I personally would choose to go on, if there's no UTI, to make a cystoscopic examination. You perform that, and interestingly, this doesn't really look like Leadbetter-Politano procedure because it's really long, like something combined Leadbetter-Politano and also Cohen. And you are right to just make unroofing of the ureteroneostomy, because you have to just see where the obstruction, and also have to see the entrance point. So, but I would like to ask you, did you perform any retrograde pyelography just before starting to make the unroofing? And also at the end of the unroofing, did you make any retrograde pyelography to determine where the obstruction in the stricture, especially if the ureter is narrow? What's the length of the ureter to determine that? Did you perform that?
Yeah. So first thing is definitely this patient remained asymptomatic for 7 years. But I personally think this problem is not recent. This was early postoperative, but patient remained away or then presented when he developed pyonephrosis and fever. Probably he might have small little pain, but he doesn't present it to us. So when we did cystoscopy, we did antegrade and retrograde study both. And surprisingly, when we put the guide wire from antegrade way, it goes straight forward and very easily, and you see the guide wire going through the bladder and through the ureter all the way. So that is why you are right. There's a beaking of the ureter outside the bladder on antegrade study. But when the guide wire was going smoothly and there was free contrast was going in, so we decided that might be a long tunnel which leading to obstruction. But we were wrong. We realized later on we were wrong. It was not a long tunnel which was obstructed.
Okay. I also would like to say that to unroofing, that ureteroneostomy will also help if you just do the definitive surgery. Will also help us to not leave any stump in the bladder. So I appreciate your approach. So we can continue. If there's any comment from the Dr. Miglani also.
Yeah. Since you put a antegrade percutaneous nephrostomy and he presented after 7 years, I presume he might have been asymptomatic, but yes, the damage that the reason that he has presented now must be dating back to the surgery time. Pre-operatively, he must be having long tortuous ureter, and very often we get very significant length of ureter, which is redundant while we are doing a reimplant. And I don't know who the initial surgeon would have been. Was it yourself or somebody else had done that? The
It
first
was
surgeon?
somebody else.
Somebody else. So, in the zeal to have a long subureteric submucosal tunnel, he would have reimplanted, and it would have had an ischemic necrosis towards the end. Probably that led to this complication. Anyways, we go ahead with what you did next.
So after we removed the double J stent,
Mhm.
unfortunately, this patient presented again 3 months later with the same complaint with fever and flank pain. And he presented again and again multiple times. He was managed conservatively, but due to persistent or recurrent symptoms, pain, fever, and worsening heart nephrosis, we decided to investigate again. This time we thought, no, because we have shortened the tunnel and there was a patent ureter, it might have gone into refluxing again. So we again performed MCUG that showed no reflux, and there was smooth bladder and urethra. So then this time we thought this is obstruction, obstructed megaureter, and that confirmed on a DTP scan as well as intravenous pyelogram. Here's the intravenous pyelogram. You see the same picture as it was in the antegrade nephrostogram a year ago. This is the typical beaking here at the end of near to bladder, just entering at the level of hiatus. So after this, we decided to revise this reimplant, and we did it this time by laparoscopic reimplant with ureter tapering with sausage. And here is you see the very large size dilated ureter. We dissected this ureter, and this we measuring the ureter. This was 3 centimeter in diameter. And then because there was no redundant ureter, we already reimplanted to make an adequate tunnel tension-free anastomosis. We have to make a sausage and we tailor the ureter by XCN, and then the technique, and then we transected it, mobilized the bladder, hit with sauce, so that we can do a tension-free anastomosis with adequate submucosal tunnel. After the sausage, we incise the detusser by preserving the mucosa, and this we reimplanted by modified Leach-Garaga technique. We did mucosa to mucosa anastomosis with 5-0 PDS. First, we repaired the posterior wall, and then we put a double J, we will put double J stent. And then completed our mucosa to mucosa anastomosis. And this is U stitch for advancement of ureteric orifice. And this is alignment stitch to align the ureter into the detusser tunnel. And then this is we buried this ureter with this Stratafix suture in a continuous way. This is the final picture. So this reimplant was done 1.5 months ago. Patient is asymptomatic. So far, double J stent in situ, and there's minimal left hydronephrosis with empty bladder. And what we learned with this case, initially we thought this is a long submucosal tunnel leading to obstruction, but actually this was a narrow hiatus that was leading to obstruction and causing obstructive megaureter. Thank you very much.
What do you think? It took 7 years for this narrow hiatus, to become narrow, and the megaureter was there since the beginning.
Yes, you're right, but as I mentioned earlier, this was not this. The problem was initially postoperative, but patient presented now when he developed pyonephrosis. But this was an early postoperative complication, not 7 years later complication. In my view, it might.
But 7 years is a very long time.
Yeah. But surprisingly, so the patient has not lost his function.
And it was not lost.
About 37% at that time.
Then 26 and now 30%.
Yeah. Yeah, it means there's not significant obstruction. That was, he was surviving and the function was maintained.
It was a partial obstruction.
Yeah, might be.
Baran, do you have comments?
Yeah, I will also like to make some comments. For this case, of course, obstruction is really apparent, and since the antigraphy showing the spin point and also the long-term pass already, so it is not really possible to do some endourological solution. We cannot suggest for such cases. So for operation, maybe we can discuss what we can choose as a surgery. I mean, intravesical or extravesical. For such condition, I personally prefer to do extravesically. I also had 2 patients like that referred from another center. One was especially a very, very rare case to check the extravesically the condition laparoscopically, really give a lot of information about the ureter and also the bladder. In my case, what I saw, maybe some of you just may remember this case from the international meetings I presented. the ureter was just passing through the sigmoid column mesentery. I mean, the surgeon just passed the ureter from the sigmoid mesentery. So it is really better to just check all the things laparoscopically. So I prefer Lick Gregoire technique and also laparoscopic approach. For the surgical technique, we also have to just consider and also talk about the tips and tricks for the surgical technique. I would like to just appreciate the approach of the Dr. Zafar. He just put the firstly measure the length of the ureter and also diameter, and then for tapering, for making ureter better to anastomosis, he didn't make the transection, just make the tapering and then transect it. And sometimes other surgeon might prefer to just take the ureter out and then do it and then get in and go on. So this is a good trick, of course. During the sausage procedure, I would like to ask Dr. Zafar, the important thing is when you're just making the sausage, you have to be careful about the genitofemoral nerve. As far as, if I'm not misinterpreted, I saw your two suture just passing through the genitofemoral nerve. Did the patient had any anterior tight numbness due to this
No.
interrupted suturing? No problem. Okay, then great. The other important thing, sorry?
No, we actually save the nerve. That is what you're mentioning is a tendon. It's a glycinic tendon, not the nerve. If we took the suture from a tendon, not the nerve, we save the nerve. We exclude the nerve from suture. And then that's my way to taper the ureter. I do not transect the ureter because that helps a lot while keeping the ureter in tension traction. Once you divide it, then it's difficult to taper and repair it. So first I repair it, transect it, then at the end I transect it from the bladder.
Yeah, also we also have to emphasize that the U-stitch for alignment just before opening the mucosa, that's also important, and also for alignment, the last stitch you just put at the end of the ureter, this also make the operation time very short and easy. So this is also a good maneuver and a good trick to do. So up to now, that's what I would like to say.
There are some questions in the chat box. I would like to read for everyone's benefit. Mr. Sherif Shehata is asking if MR urography could be of help in the second surgery. Would it have changed your decision? Like
what else? Because we have done already anterior nephrostogram, we had IVP, and MR urography is costly and not available in my center. So if we have a simple investigation and the high-tech investigation not available, yes, it can be helpful, but if it's available.
And then if we assume it to be obstructing megaureter, what could have been done differently? Anything different you could have thought of doing, or you had thought, but did this what you did?
Yeah, if initially we thought this is obstructing megaureter due to hiatus, I should have go straight forward in the first time for redo reimplant, rather going and taught me.
I mean, you didn't think of enlarging the hiatus extracyclically a little bit, that it might relieve the obstruction and.
No, I think that enlarging the hiatus in a reimplanted ureter is much tricky. You can devascularize jeopardize the blood supply of the ureter. So the best would be the reimplant, redo reimplant rather opening the hiatus only. Because as you see, when I transected this ureter after the tapering, there was a complete narrowing and probably there was ischemia at that time.
And do you think balloon dilatation at the hiatus could have helped after the deroofing?
Yeah, that after the opening of endoutertomy, the second option was the balloon dilatation, but again, that the results would be plus minus, and that the results would be plus
think of
minus.
that at that point of time. You didn't think of the hiatus level obstruction when you were doing when the ureterotomy. So you would not have gone there anyways. We thought, let's say, metal stenosis, this ureteral orifice stenosis that has caused the back pressure, rather than you thought later on that when it happened again, that you went upstairs again and did the entire thing as a redo. Yeah.
Okay. Thank you so much. We will listen to Dr. Sabine for the conclusion because time is over for the first case. Sabine, please, can you conclude? Sabine? Can you unmute yourself, please?
Yeah,
Yes.
I couldn't, but Asin helped me. Fantastic. Thank you for allowing me to make some words of wisdom, say a conclusion and take home message. I think one really important thing that was discussed in this very interesting case is that when the kid is really sick, when we have a febrile UTI and pyonephrosis, it is most important to treat this first and not go for reconstructive surgery or actually solving the problem straight away, but treat the infection first. So this is something Dr. Tokar said, and I think this is very important to remember. Secondly, I found it very interesting that the unroofing of the long tunnel was tried. It is something that can be tried, but might not always be successful, as in our case, and careful follow-up is needed. I think this is another take-home message from this case. Whenever we do surgery, especially re-implants, we need to do careful follow-up. I know that this is difficult in some countries and people might not show up, but even ultrasound follow-up, seeing the increasing diameter of the ureter might have saved the kid from the infection because the obstruction might have been realized beforehand. And I believe even now, after the second re-implant, follow-up is important to rule out obstruction. So thank you very much for sharing the case. I think we did learn a lot. And I think it is time to go on to the second case.
Yes.
Thank you very much. Thank you.
Thank you, Dr. Sabine.
Awesome case, awesome discussion, and awesome conclusion. And we will move the second case that will be moderated by our president, Dr. Sherif Shehata. Dr. Sherif?
Hello, everyone. I thank you all in this presence, and it's my chance now to invite Dr. Sibel Tiryaki to present her case in this nice symposium. Please go on.
My case is a 7-year-old girl who was operated for myelomeningocele and was followed for neurogenic bladder in another hospital. She does CIC 4 times a day and on oxybutynin as 2 dosages and under prophylaxis. She underwent a bilateral sting procedure for VUR when she was 3 years old. And these are images after her surgery with a really nice looking bladder for a neurogenic bladder and good kidneys with no scars. She presented to us at age 7 because she still had UTIs. Some of them were with fever. She had diapers for both urinary and fecal incontinence. But mom said urine leaks were not that much. These are the images at that time. As you see, bladder worsened, reflux recurred, and kidneys doesn't look good with scars and hydronephrosis. So if this was a primary reflux, UTI under prophylaxis meant surgery, but as this is a secondary reflux, we have to first manage bladder and bowel. So what we did first was we checked if the bladder was managed properly. So we performed a urodynamic study under anticholinergics at the dosages she was using. Her capacity was 2/3 of the capacity expected, and almost all was a post-void residual. She had a bad compliance and abnormal contractions through the filling phase and around 40 centimeter water. And the restored leak point pressure was 32 centimeter water. So we thought that the bladder was not managed properly. We increased the oxybutynin dosage. We increased the number of CICs, and we planned a reassessment in 1 month with CIC diary and sonography. We also evaluated if her bowel was managed properly. As you see, all column was full with impacted stool. So we took her into our bowel management program, which starts with regular enemas, oral osmotic laxatives, and reassessment in 2 weeks. Unfortunately, she admitted with a febrile UTI even before her first follow-up visit. It was a moderately resistant E. coli, so we had to hospitalize her. And then we had to think we had another UTI before we were able to manage her bladder. So what we first did was we changed her prophylaxis because the microorganism was already resistant to the prophylaxis she was taking. But unfortunately, she admitted again after her treatment and prophylaxis in 2 weeks, again with another infection with Pseudomonas aeruginosa, which was even more resistant. So what we shall do now, we thought that it's better to do to manage bladder and surgery together. And we planned bilateral sting procedure with intradectoral Botox injection. How we do it, we start with sting procedure. We do it like a classical sting if the anatomy is normal. And we first do sting because when you start Botox, there can be hematuria and it might obscure your view to see the ureteric orifices. And then we continue with intradectoral injections. We use onabotulinum and we do it 10 units per kilogram. As you see, some of them are intradectoral, some of them are submucosal. We prefer intradectoral, but as in literature, it doesn't matter. So some are like that, so it's not so important. Now she has no UTIs for 2 months and she is dry between CICs. She still has fecal incontinence and constipation, but she's getting better. And our plan is we will follow her with scheduled sonographies and we never stop doing them. We do them until adulthood because we had some late obstructions with sting procedure, especially with the cases we performed PPC. And then we transit them to adult urologists. So they are being followed all the time. We are not planning to do any CUGs because it's a secondary reflux and she has UTIs and she doesn't have now. And we will follow her UTIs, your CIC diaries, and if she is dry between CICs and if we are in doubt, we can perform video urodynamic study. And for her bowel management, we can perform Malone integrated colonic enema or pristine bowel irrigation system can be offered to the family. But we tend to wait for them for a little bit because we first want to see if bladder can be managed before surgery, without surgery. Then we can do both surgeries together. And last but not least, nephrologist follow-up is actually mandatory both for her disease and her scarred kidneys. Thank you.
Thank you very much, Dr. Sibel. And I think a lot of questions and comments will coming from our experts. We will start by Professor Alaa Ghoneimi. Please go on. Right.
Yeah, thank you very much for your nice presentation. I have many questions. I mean, first of all is in your protocol, why would you use anti-prophylaxis in a neurogenic bladder with CIC?
We don't do it
because
in all cases, but this girl had UTIs. She presented to us with UTIs. Not in all cases. We don't use it in all cases.
We don't hear you.
Sorry, we do not use it in all cases, but this girl presented to us with UTIs.
We don't hear.
Sorry, can you hear me now? Can you hear me now? Sorry.
Please come closer to the mic, please.
My voice okay now? Sorry.
But
can you hear me?
No, not really.
For
Sorry.
us,
can you now?
Your child, no, your child was already managed by CIC from the beginning with anticholinergic. That's right?
Yeah.
Yeah. So why do you add anti-prophylaxis if they have reflux?
My voice is not coming.
No.
Dr. Sibel, can you pass a little bit to the left, please? The other side.
Sorry.
Yes.
No.
Yes.
Okay. Sorry.
Okay.
So she presented to us with UTIs. We do not give prophylaxis to all kids with neurogenic bladders. This kid presented with UTIs. She already had UTIs when she came to us. She came to us because of UTIs.
Yeah, but this is just the first thing that even if you put a prophylaxis, it did not change anything. She kept doing UTI. So I think that prophylaxis for this patient is just increasing the incidence of multi-resistant microbes after. So you need to manage the bladder, but not the infection. This is my question. Second thing is that, did you check how she is doing her CIC? That's why, because third thing is that you did your urodynamic, but you didn't tell us when the reflux is starting. Is it starting with high pressure or with low pressure?
My voice is okay, right? The prophylaxis is, I know it's a debate, but in this case, she presented always with febrile UTI, so we were afraid to stop them. And we changed them until our bladder and bowel was managed. The second thing, yes, we always do check how they do CIC. We have a nurse for that, and it's how we start following patients. And for the third one was
the other thing is
she already had a VCUG, and we didn't want to give her more radiation, so we did only urodynamics in that case. But for the following ones, if something happens, we are planning video urodynamics.
Yes, but this is my question is coming now, is that you have done the diagnosis of high pressure, low compliant bladder. That's right?
Yeah.
Yes. And then you managed with a treatment, which is the Botox to decrease the pressure and decrease hyperactivity. That's right?
Yeah.
You did not control after if it is efficient or not.
But she's now between CIC and she doesn't have UTI, so I think
no, you cannot. I don't agree about that. If it is just for hyperactivity and incontinence, yes. But if it is for high pressure, you have to rule out high pressure. How do you know that your Botox was efficient for high pressure? We don't know. You are only treating the infection, which is the Botox cannot treat the infection.
No, but
no, stay the other side. Stay the other side.
Sorry. And hydronephrosis regressed, so I can have an idea on that.
No.
We do not always do video urodynamic studies in the follow-up if the patient's clinic and sonography and everything goes well.
I don't agree with that. It's all the recommendation, all the guidelines in neurogenic bladder. You have to do a routine urodynamic study to exclude and rule out and control the high pressure, because you can have deterioration of the upper tract with just without infection. I mean, without hydronephrosis. You don't need to wait for it.
Thank you, Dr. Alaa. We'll have many comments also from Professor Muhammad Arshad. And actually, didn't look simple, but they will, for educational purpose, open a lot of points for the guidelines to be followed. Please, Dr. Muhammad Arshad.
Yeah, thank you very much. And then thank you very much for presenting this case for discussion. And I think when we deal with secondary reflux, so we have to concentrate more on the primary problem. And the primary problem in this case is probably the pressure of the bladder, and also secondarily because she has meningomyelocele and the fecal constipation also. And this has been addressed by evacuating the bowel, but that probably is still had fecal infection, and that also leads to difficulty in emptying the bladder. And the philosophy is that whenever you give more time to stay urine in the bladder, it gives more time for bacteria to replicate, and the load of infection increases. So probably one is that you have to increase the CIC, and maybe a nighttime catheter drainage may also help to decrease the secondary effect of this bladder, non-compliant bladder. And probably I think more emphasis on hydration alongside the drainage of the bladder, that will flush the bacteria more to decrease the infection, and concentrate even more to the bowel management. And that may help in decreasing the incidence of UTI. I'm not sure that whether to, because a lot of the time we get patients and they have reflux, which is secondary, and to treat this problem, which is due to bladder malfunction, primarily will not resolve the issue. So you have to concentrate more on bladder emptying and try to reduce the bacterial load to decrease the infection. Thank you for presenting this.
Actually, Dr. Sibel, you can see the points. If the organism is coming from the intestines that you every time isolate from your infection, because I think it looks, because you have this meningeal case, that you are just delaying the intervention until it go to the adult or nephrologist. But you can proceed on to keep the bladder and the upper kidney to be protected. So I think, Dr. Sibel, do you hear me?
I didn't understand the question, sorry.
Because if you have the organism in the urine culture from UTI in this neurogenic bladder, is intestinal one, you have to do something, not just delay, and bowel management is not enough. It is a meningeal. So you can even do like a malone at the same time this time, and as mentioned by Dr. Alaa and Dr. Arshad, that we don't need to just delay, because this is a high pressure zone neurogenic bladder, delay the effect or the complication until later on. We can interfere now. So maybe my question now to both Dr. Alaa and Dr. Arshad, before we go to the comments by Professor Amine, is there difference between primary and secondary reflux in this case?
Yes, if I would say, of course, yes. I think that in this case, it's a typical case of secondary reflux, neurogenic secondary reflux, because Sibel had given us the approval and the confirmation that it was in high pressure bladder. So if the blood pressure was very low and everything, and you would say that, okay, it is just associated congenital reflux, primary reflux with neurogenic bladder, which is exceptional. So in such case, yes, I would do it the same. But she gave us high pressure bladder with reflux. So we cannot treat, I am sorry to repeat it because it's extremely important. That's how we lose kidneys and we go to renal failure in neurogenic bladders, which should not happen in neurogenic bladder nowadays. I mean, you have to treat the high pressure of the blood. Which means that if you started the Botox, you have to continue. If the Botox is not functioning, we have to control. If we found out that the pressure is high risk for the upper tract, in this case, you have to go to the next step, which is, of course, bladder surgery, bladder augmentation.
I want to say something. I totally agree that we have to control the bladder pressure. We just don't check them if things look good every time. We go with Botox, go on. If the clinic is getting better, if no UTIs, if hydronephrosis is getting better, then we do not repeat urodynamic studies every time. We do it when there is some problem or in ages of tethered cord. And for the Malone, we do Malone. We don't push it to the adulthood, but we just wait to see if their bladder will need any surgery. In that case, we want to do them together. And with our bowel management program, we can control bowel pretty good. Then Malone stoma is just another route of enemas, which increase their quality of life. But we don't push it to the adulthood. We do it. I think I mistold it, but we do it, but we just delay it until we are sure about their bladder.
Thank you, Sibel. Dr. Arshad, your opinion that it can be done post-management surgical if there is Botox is failing, and for the bowel control, it can be done at the same time since this time at 9 years age?
Yeah, I think I agree with Dr. Alaa that if it has to be documented that your treatment is giving you desired effect and not wait until the problem occurs. So because the kidneys do not recover if the injury occurs. And that is what probably Dr. Alaa is referring to. And so you have to probably work at both ends, the bladder and also the bowel simultaneously to improve the status of renal function and prevent UTI in this child.
Thank you,
Sorry,
Dr.
one
Arshad.
more.
And now, Dr. Amine, Ksia, can you please give a wrap-up of the comments regarding this point?
It's difficult to conclude after such eminent experts and such nice presentation, but perhaps I will say some few words. So this patient with the myelomelancocele are very particular, and by sure they do need to be discussed in a multidisciplinary way. You have many therapeutic options, and you should adapt your this option to your patient, because each patient is particular, and you should adapt this therapeutic option. And by sure, and it was nicely said by Dr. Sibel, this patient will need follow-up perhaps all their life, and that's why you should emphasize on the transition for the urologist and the nephrologist. Thank you.
Can you give last comments, please, Dr. Amine, because there is a lot of juniors in the audience, participants, to highlight. Yeah, just comment for the how they proceed on the pathway or guide.
How they proceed, excuse me?
How they proceed in the management of secondary reflux, steps one by one as to be concluded for them. And then we will shift to the third case.
Yes, so of course we should manage the bladder, do the urodynamic study, and after you will decide what you will do. You can have also the deflux injection and also Botox, and in some cases we can do the enlargement, but I know that enlargement of the bladder is less and less done now with the medical options.
Thank you, my dear friend, Professor Amine Ksia from Tunisia. And now, for the time being, we will shift to Professor Baran Tokar for the third case, please. Thank you.
Okay, thank you, Dr. Shehata. Now, we are going to discuss our third cases, and the title is the management of vesicoureteral reflux in a patient with duplex collecting system. This presentation is going to be done by Dr. Alex Turner from UK, and there are two distinguished faculty for case discussion, Dr. Sherif Shehata and Dr. Sabine Zundel, and the brief conclusion will be done by Dr. Miglani. Okay, Dr. Turner, please.
Thanks very much, and thank you very much indeed for the invitation to speak to this group. Greetings from Leeds, where I'm sure the weather is not as good as it is with you guys, but and it was also a pleasure to attend ESPU recently in the Education Committee course in Ankara. So thanks very much for the invitation. And I hope what this demonstrates today is a case which gets you thinking about the management of reflux in a duplex system, some of the pitfalls that you might encounter, and raise some debate about some of the controversies in the management of it. So we'll start with essentially a typical presentation. If we can move it on. There we go. So a 4-year-old boy presents to the clinic with recurrent upper urinary tract infections, has had an episode of urosepsis, admitted to hospital, requiring IV antibiotics. And he's been referred to your clinic because of the findings of the ultrasound. And the ultrasound that was performed showed this. This is a longitudinal section of the bladder, and you can see behind the bladder that there is a dilated left ureter, and you can also see that there is some uroepithelial thickening. The images of the upper tract here in the kidney shows what looks like a duplex system with a non-dilated upper moiety, but what appears to be a dilated lower moiety. And so really, well, if you get this picture and see this patient in clinic, I'd ask you, what next? How do we proceed with this? And so I'd ask the group now to discuss how you'd proceed.
So if I may start, I'll ask the first question. And what I would be interested in is what...
we can start a discussion. Dr. Shehata?
Okay. I can follow him.
Okay. Can you hear me?
Yes, we can hear you.
Perfect. So in duplex systems that do cause problems, and we do know that not all duplex systems actually cause problems, I find the assessment of the differential function very important. So what I would like to know is what is the function and where does the dilatation in the ureter come from? Is it reflux or is it obstruction? There is a probability because it is the lower tract that is enlarged, I believe. Do I remember that correctly, Alex?
That's right, yeah.
So I guess the likelihood is more reflux, and we're talking about reflux during this webinar. So maybe it's actually two things pointing us towards reflux. But I'd probably do a VCUG and a functional assessment to know the function of the different moieties. So this is how I would proceed.
That's great. Thank you. So yeah, the obviously in the clinic we'd talk about the history and examination, work up as you would do any VUR, work up as a simplex VUR if this is what you suspect. Obviously, we've just talked about a situation where there's secondary VUR, but obviously establish the possibility of the secondary VUR if that's possible with other symptoms. Urotherapy workup, optimize any bladder and bowel dysfunction, IV antibiotics, then a treatment dose and then prophylaxis until you get to the bottom of things. And then, of course, further investigations. And I agree entirely with you. You'd want to look at some functional analysis. This is a DMSA showing that the right side has got a nice contour, looks like a normal kidney. What appears to be the upper moiety of the left duplex system also appears to have a normal contour. But the lower moiety appears to have less function there. So there's quite a strong differential there between the upper and lower moiety. And furthermore, I agree entirely, we do a VCUG. And on this picture, you can see the classical drooping flower or drooping lily appearance of the lower moiety there. And according to the ureter, some tortuosity there, some dilatation. This is sort of grade 3-4 reflux, and there's no reflux into the upper moiety. There's no reflux into the right-hand side. It's really important to look for that 20 or 30% possibility of contralateral reflux into the simplex kidney on the other side. So yes, we've obviously discussed a little bit about that, and I mean, we can move on now to have a think about how to manage the general principle. Oh,
Just before going, maybe Dr. Shehata will make a comment. Any comment from Dr. Shehata?
Yeah. Actually,
Or any questions?
as Sabine said, we have to differential function of the post kidneys and the VCUG, and at the same time we can add something like MRU to define the anatomical morphological parts to see, because the upper one is functionally okay, the lower to see what is going on later on to decide the next step in management, as Alex is expecting to do. Okay.
Hey,
Can I? Yeah. You comment, Alex.
No. Hey, please go ahead.
So I was wondering about the type of diagnostics as well. MRI is an option, as Sherif said. How come you did a DMSA and not a MEC3? What was your reasoning here?
Yeah, that's a really good question, and I think it's sort of two approaches to that. Firstly, I think as we're going to come on to, if we're thinking that this is a standard anatomy, like you said, lower moiety dilatation, lower moiety reflux, with what appears to be a normal upper moiety with no dilatation and no concerns about obstruction, for instance, then the DMSA is going to give us a better split functional analysis of function, and indeed you'd be able to differentiate between the upper and lower moiety in terms of function. MAG3 can do that less well. I think if there was a possibility of obstruction, then a MAG3 certainly would be of use. I'd probably in those cases suggest doing both a MAG3 and a DMSA, because I think the DMSA is much better at defining function and looking at the outline and looking for scarring, discrete scars.
Yeah.
But yeah,
you're absolutely right. Very nicely put. I personally prefer the MEC3 because I believe it probably tells us enough about the differential function and can tell us something about obstruction, even though I do totally agree that the region of interest in the MEC3 is often a problem, and depending on how well it is done, we might get results that don't truly represent the anatomical situation.
Absolutely, point taken. Yeah, I think it could go either way, and probably it's more the way that the policy is in the hospital, maybe on guidelines and whatnot with that. But the points that have been made. Sorry.
Totally also in the same line as Sabine said, that we have to, before we are going to the next step in management, to know where it is according to Meyer-Wegert law. Is it classic one or rare one? Because I think it's one of the things that will be direct us in the pathway of the management.
So yeah, I mean, it's almost as if you've seen the presentation. I mean, it's fantastic. This nice discussion. So I'll move on at this point, because we've got to really imagine not this case now. We're talking about any case with reflux in a duplex system. You've got to identify what the clinical and functional issues are in both moieties and the other side as well. So you could be in a situation where you've got no UTIs, no scarring. So you could actually consider treating this conservative, just like you would do with a simplex kidney. But then, as you've said, what is the upper moiety doing? That will change your approach entirely. You know, in an obstructed system with a urethrocoel or ectopic ureter or something like that, that's going to change your approach. Remember, of course, the top-down, bottom-up approaches to this. And as you said, be certain the Meyer-Wegert phenomenon applies. Stephen's law says that actually the opposite applies in rare cases. So the upper moiety actually inserts cranially and laterally, not the lower moiety. So actually, when you're talking about MAG3s, doing further tests, retrograde studies, cystoscopic examination of the bladder, put a tube into there, fire some dye up, make sure you know which side is actually, be confident you know which side is refluxing, because you might have an appearance like this. This actually is an upper moiety with a normal Meyer-Wegert phenomenon applying. You've got an everted urethrocoel with reflux into what looks like a very blunted and non-functioning upper moiety. So it is vital, as you've said, to determine which segment is refluxing. So if the Meyer-Weigart rule applies, so if we've got the expected anatomy, if the upper motor cortex and the ureter are normal, and you're dealing with just pure VUR into the lower moiety of a duplex system, where it has caused some UTIs, it's caused some scarring, like in this case, it's caused the child to be unwell, what do we do? If there's no function in the lower moiety, then I think we would agree that a heminephrectomy done would, so a top-down approach to remove that segment of the kidney, prevents long-term blood pressure concerns, and along with sort of a limited ureterectomy. You may even, in some cases, detach the ureter at the bottom end, and you're left hopefully then with no reflux into the stump, and the kidney, the pig kidney segment has gone. But if there is good function in the lower moiety, and this particular case had something like 15–20% there, you've got some options. And this is where the controversy applies. So we would think maybe about endoscopic correction. We could think about reimplantation of the ureter, so a duplex reimplant. You could also sometimes consider something like a ureterostomy with division of the lower motor ureter below. Now, I'm not going to go on about that because this is not something I'd usually consider. I think it risks both kidneys, could be of some use in some cases. But where I want to concentrate the debate is about the role of endoscopic correction in the duplex system. So I draw your attention to this picture, which shows a simplex system, and ask the question, what do we need to create a good bleb to correct the reflux in a ureter, simplex ureter? Well, we need one thing. We need a good muscle sitting behind, good detrusor sitting behind the ureter. When you inject whatever you're going to inject, deflux or whatever, into the submucosal space, it pushes against that muscle to deflect the material into the mouth of the ureter to elongate the tunnel and correct the reflux. Consider what we have in a duplex system. What do we have behind, according to Meyer-Weigart, with the lower moiety sitting above the upper moiety? There is no muscle sat behind there. So when you inject the deflux, the material will push down into the upper moiety ureter. It will not cause an adequate bleb in the lower moiety that you're trying to correct. And also, secondarily, you could injure the upper moiety, you could obstruct it. And so my practice is that in these circumstances, with only VUR, clinically requiring treatment, with the expected anatomy, with good function of the lower moiety, a duplex reimplant is preferred. And that's the conclusion of my talk, but I suspect that might provoke some comment. So I open it up for debate.
Thank you. Sabine, would you like to start, or Sherif?
Yeah,
okay.
Thank you, Alex, very much. Actually, you are discussing a very important point. We don't need by injection or endoscopic management to increase obstruction. We have to make good drainage. So if you don't have a muscle, you can think for something like ureterostomy between the both of them. And also maybe in the coming by robotic or something, you can make like side-to-side anastomosis of the intestine, and you can use only one endoscopically. But the point I want to just emphasize that the rare options not following the Meyer phenomena is almost 20%. Meyer classic one is 80%, but still 20%. You have to look by cystoscopy and go on. And now, Sabine, please. Okay.
So thank you very much for this presentation. I think it is a topic of huge arguments and very different opinions. And I would like to start with your comment on if there is very little function. Let's say we are talking about 5%, which is regarded a non-functioning moiety. You would do heminephrectomy, and you suggested that we might all agree. I disagree. I did grow up in a hospital, in a system, and was taught that heminephrectomy is the thing to do in these sort of cases. And in selected cases, this is still what we do. But I do know pediatric urologists who have changed their opinion during their practice, and they have been practicing for years and years and have done many safe heminephrectomies and then have lost some kidneys, either due to vascular injury or to vascular spasms, which led to restricted perfusion, not being able to salvage even with interventional radiology. And they have totally turned their back on heminephrectomies and say never do a top to bottom approach. They would always go for ureterostomy or reimplant, even in very low functioning moieties, just to definitely save, not risk the, in your case, upper moiety. So I believe there's a lot of ways to look at this, and it is most important to operate and treat our patients with the least possibility for complications. So we need to take into account what we know how to do, what we do safely. And you mentioned it before, ureterostomy, high up, which might cause a yo-yo effect, or lower, which might risk the healthy ureter a little bit more, is an issue, but might cause obstruction, which can be reoperated and does not kill the kidney. So do what you know best and do what you do safely, but there's a lot of ways to treat this patient.
I agree entirely.
So thank you for bringing it up. I think, again, there's a lot of different options. My comment about the endoscopic repair, I totally follow your arguments about not having a good muscle, not being able to have the bleb. It sounds super logical, and it sounds we should never, ever try endoscopic treatment for these cases. My practice shows me there's a lot of kids that don't have any infections after I do an endoscopic injection. With all the discussion about not risking the healthy upper moiety, I reckon the endoscopic treatment is worth a try. Data shows us the likelihood of success is a lot smaller than in a singular system, but it's not null. Therefore, if I'm talking about reimplant as my second best or maybe best option, may I not try? It's going to be more difficult during the reimplant because I need to pull all the deflux out. But if I have, I don't know, 50% of kids that don't have infections anymore and stable function, why not try?
Of course, the data is out there. We know that it is successful. I'm playing devil's advocate, of course. and the thing is, I say to my trainees, I say, I never do this unless I do it. and of course I do it. But yeah, there is more than one way to skin a cat, and yeah, it's whatever works in your hands. And I think it's more to outline the potential risk. And I think, you know, when training, it's important to recognize that, you know, that there is some danger there if you're not quite sure. You know, obviously in experienced hands, you know, it's going to work well in many cases.
When the white hair come more in your present hair, it will be more wise in decisions. Thanks.
I don't know about that.
Okay, just before getting the brief conclusion from Dr. Miglani, there are some comments in the chat box, and I would like to ask to Dr. Ghoneimi. He said, Dr. Turner, endoscopic injection of duplex system is not obligatory obstructive, he says. So maybe Dr. Ghoneimi will make comment on that and then can answer you.
Yeah.
Yeah, please, Dr. Ghoneimi.
I was just commenting, saying that I was surprised by this categoric decision that don't do endoscopic injection, and which I really, I mean, we have to judge it endoscopy and to see feasible or not feasible. In my memories, I mean that even in publications, we have done this review a few years ago, at least 15 years ago, on ureterocele and duplex system, and the injection of Reflux for the duplex system is 50% efficiency. So why depriving this 50%? It's just an injection, and so it's but obstructing. I don't think obstructing. Of course, you have to evaluate it endoscopically and judge. We cannot be categorical to saying that there is no floor. When I inject, it will obstruct the other ureter. Sometimes it's not like this. So
yes, absolutely, it's just possible. Yeah,
it's like all endourology, all things that you will judge on the spot if it is feasible or not feasible. But if it is not feasible and you have decided to treat that child, I wouldn't wake him up. I would do the reimplant in this case. That's all.
Yeah, absolutely. Yeah, nothing is for definite. No, it's just like I said at the end, for me, it's preferred, but there's all the evidence out there to suggest that it can be successful. And yes, it's not mandatorily obstructive at all.
Okay, thank you. Maybe we can pass it to Dr. Miglani for the brief conclusion. Please, Dr. Miglani.
Yes, it's a very interesting case. It's actually a typical Wiegert-Meyer syndrome that Alex has presented. And I am just going to present to you the other side of the coin, where half the world lives. You guys are talking about where everything is available at the drop of a hat, whereas in my country, we are a resource-constrained developing country, and things like deflux and all those things are kind of available, but not to all and every patient. And some institutes get a supply from the government maybe, but most of the patients over here have to afford from their own pockets. And they want a short treatment, and which remains till date a common sheath reimplantation for such a case that you have presented. And in duplex, again, because it's a technically demanding thing to inject deflux and then risking the obstruction of the other moiety. So most people here, fearing failure, would go in for a reimplantation in my country rather than trying. Yes, of course, if there are some institutes get grants and they've got a free supply of deflux on a project basis, like on a research project going on basis, they would be liking to do the approach that you have just suggested. And that's all I would like to say. Otherwise, Ms. Sabine had beautifully summarized whatever you have presented, and there's nothing more to add except from my point of view, from the Indian point of view, or from even Pakistani point of view, or the developing countries. Many participants, 170 participants are there at the moment, and many of them are from poor countries who do not afford these kind of treatments. So I think this is a very enlightening talk. Yes, there are many ways to do the same thing. And for the minimally functioning kidneys, I personally have an experience of somebody who had valves and very bad 8% functioning kidney, whom I had requested a nephrectomy. But he put his foot down. No, I want a reimplant only. I don't want my child's kidney to be removed. Whatever it, I will take the risk. And I have followed up that child for almost 20 years now. The kidney has come back to about 28% from 8%, slowly improving. So even badly functioning kidneys in kids, over the long term, they do improve. And we should do all we can, maybe reimplant or maybe put a deflux, so that if the reflux is controlled and UTI is controlled, we can save certainly the residual nephrons that are there. Thank you very much.
Okay, thank you. So we are now concluding the panel. So I would like to hand over to Sabine for the next panel to start as a moderator. Sabine, please.
So last case, and I'm sure it's going to be as interesting as the ones we've heard. I invite Dr. Marei from Egypt to talk about a very similar case with bilateral duplex kidneys in this case and preserved moiety function. Please share your case.
Can you hear me now?
Perfectly.
Yes, so thank you for this opportunity to present this case and to participate in this meeting. Good afternoon, good evening, and welcome everyone, depending on where you are in the world. So this is a case I'm presenting from Cairo University Children's Hospital. So duplex systems are often complex in decision making, and traditionally the upper moiety in many cases is expected to be dysplastic. However, in some cases, in a percentage of cases, there is functional symmetry which may exist, and that might affect the surgical indication. So this case demonstrates functional preservation, altering the surgical choice and the reconstructive choice over ablative surgery. Are my slides moving? Yep. So this is a 4 to 5-year-old boy who had bilateral duplex kidneys with bilateral vesicoureteric reflux. He had a left reduced kidney function that was 15% on a DMSA, and he presented with recurrent urinary tract infections and VOR-related bladder symptoms. So we will discuss the imaging abnormalities subsequently, which showed a duplicated system on both sides, hydronephrosis, and intrarenal symmetry between both moieties in each duplex kidney. So you can see here on the right side that is a DTPA of this child, which is showing good drainage on one kidney and low amplitude on the other kidney, but still with good drainage. Both kidneys were showing on the DTPA, but the left kidney is obviously smaller. On the DMSA, that kidney was still not abolished. It had 15 to 16% of function, and the cystogram was showing a bilateral duplex system. On the left side, there was reflux into a common ureter that then bifurcated into two ureters, and on the right side, there was reflux into the lower moiety. The next picture will show that better. So you can see here that this is the left common ureter that then bifurcates into two ureters, one to each moiety. And on the right side, there was only reflux into the lower moiety. And you can see this is also a drooping lily picture. So the question at that point was whether we have a totally obliterated or dysfunctional moiety on the left side, and that bit of the kidney that we're seeing on the left side, is that only one of the two moieties? That's what I was expecting. So for that reason, I wanted some cross-sectional imaging. I was intending to get an MRU, but our radiologists felt that getting a CT urography would give them this delineation better in their hands and in their setting. So when we've done that, we found that on each side, both moieties are actually, they do have function and they are lighting up. The upper moiety is smaller on either side, but we don't have a totally absent moiety that can be taken out. So that took heminephrectomy out of the equation. So we were faced, this is the summary of the imaging. We were faced by a situation where we have a left kidney that's about 15-16%. It's not as little as 10%, which would persuade you to take it out, but still there is bilateral reflux on either side. So this is just, more details of what I've just explained on the scans. So we got to that point where we have to decide what we do for this patient, and I would open the discussion at this point to see what would our distinguished panelists think they would do at this point. What we opted to do is not to do a heminephrectomy and to go for a bilateral common sheath reimplantation for this case. But I would be very grateful to explore your thoughts on that.
So thank you very much for your presentation. You already commented on what your idea about diagnostic tools were. I would like to invite our two experts on what diagnostic tools they would have used and if they would have done something differently.
Dr. Alaa, if you can begin, or you want me to begin?
No, you begin. You are elder.
Thank you, Dr. Alaa. So thank you for this presentation. I think that in double system, it's very important to have some information. First of all, as you are saying, the differential function in the scintigraphy. Also to see if you have, ectopic position, especially for the high moiety, if you have uretocell, and sometimes you have, some complex situation. I think that you did the right diagnostic strategy for this patient, and perhaps, and this is a comment that you can see also in the chat, perhaps we can do also MRI for some patient, but I think that MRI is not accessible also for each country, and sometimes it's not possible to do MRI. But I think that I will do the same diagnostic strategy that you did, Dr. Marei.
Yes, I wanted to get an MRU, but our radiologist told me that they would give me more information about the particular question that I had, which is the symmetry between each moiety on either side by a CT urography. That was, they felt more comfortable doing that. So I just wanted an answer to my question. So that's how I went. The other thing that I wanted to do is a cystoscopy, but I deferred that to the reconstructive operation so that I don't put the patient under anesthesia twice. So I eventually did a cystoscopy, and it also affected what I've done. I will come to that point subsequently, but I did it under the same anesthetic as the reconstructive operation.
The other question is perhaps a philosophical question, and I don't have an answer for it. When you consider a moiety that is not functional, I don't know, perhaps each one perhaps will tell his experience about this.
That would involve a number of factors. On the ultrasound scan, the parenchymal thickness, for example, and the degree of that moiety lighting up on the DMSA. In some circumstances, the nuclear medicine radiologist could tell you a differential function within the kidney itself, but that's not common in our setting. So they would only tell me that the right kidney is this and the left kidney is that, but not what would be the differential within each kidney. So I wouldn't, for example, get that each moiety contributes to that % of the function that this kidney is showing up. So that's another factor, and as well the morphology of that kidney, and that's of that moiety, and that's why we've done cross-sectional imaging. If it has very thin parenchyma, if it's just a bag of urine, that's just totally demised parenchyma that doesn't have any potential for function, then that would be judged as dysfunctional.
Alaa, do you have any comments?
Yes, I think first of all, we didn't have the age of the patient, which is the first thing of diagnosis.
Sorry,
4 years old.
4 years?
Between 4 and 5 years old. So
Okay.
I started saying that, but sorry if you
No, it's
didn't
okay.
see it clearly.
It's okay. So it's 4 years old. So I think at 4 years old, we wouldn't go for a CT scan, for isotope, for CT scan, because of of course, the radiation damage for these children, especially for a girl. But
that's a boy.
Anyway, I agree with you that we always say that when we have low resources, we cannot do the MRI or do scanning. So why you are not investing in a high quality ultrasound? We'd go always away from ultrasound. If you with your pediatric radiologist invest in ultrasound, it will give you most of this information that we are looking for. Most of it. And many studies has shown that, even in our study also that was published in 2003, Journal of Urology, that what is the parallel between the image of a good ultrasound and the isotopic DMSA scan to see if it correlate or not when we say it's not functioning or not. It will not give you non-functioning, but at least it will give you an excellent thing. Second thing is that this is for diagnosis. I totally agree with you, Mahmoud, that we cannot just do a cystoscopy for diagnosis. I mean, there is a hazard for general anesthesia for these children, and I think it has to be accepted really that you need to planify the surgery for much more complex surgery. The second thing that I have to say that I don't agree about something. No, that slide before. The slide before.
Yep.
The slide before. Yes, here. Impact on surgical decision making. I think it is first, your case is incomplete left duplex system. It's not complete duplex system, which change a lot about the management of it. Even in surgery, injection, all of this will change.
Yes.
Second thing, absence of an isolated non-functional moiety ruled out heminephrectomy. No, it's not. For me, it's not ruling out. It's not because it is functioning that it ruled out. No, it is the very low function of the left kidney cannot afford partial nephrectomy.
Of course.
This is the thing, which is just, it's not because even if it will show me there is no function, I wouldn't do partial nephrectomy in a very low function full kidney, because you always lose function, a bit of function when you do partial nephrectomy. So I would go for a low tract surgery for these children and not an upper tract surgery for these children.
Of course.
So Mahmoud, I think you should continue because I think now you're going to tell us what you did.
Yes, so this slide is just, thought-provoking about what were the options that we had, but I will come to that point. But if we've already discussed most of those points, so I'll go to what we've actually done. So we've done a bladder level operation where we've started with a cystoscopy to find on the left side just one ureteric orifice. That then we've also done a retrograde uretropylography to confirm the anatomy before we started the operation. And on the right side there were two ureteric orifices. Because the reflux was into the lower moiety only on the right side, I had that thought that on the right side I might only reimplant the lower ureter if I can, but actually the two ureteric orifices on the right side were very close, that in order to do a safe reimplantation it had to be a common sheath reimplantation. So that's what we've done. We've done a bilateral common sheath reimplantation. So and I'll show that technique, which is this is the head side up and this is the foot side down, and that would be after mobilizing the ureter here. You would extend the hiatus upwards, cephalate in the head direction, and then reconstruct it from below upwards so that you transpose the hiatus upwards, and then you will have all that length to be the tunnel. So this is the neohiatus here covered, where the ureter would enter from here and then travel under the mucosa for that distance, and then these are two JJ stents coming out on either side. So we've done bilateral common sheath reimplantation with four ureter of the four ureters with four ureteric stents. On the left side, we mobilized the common stem for a distance of 2 to 3 centimeters to find it bifurcating into the two ureters, and then reimplanted the two ureters in a classic duplex way. So that's a description. So this I consider a modified Politano-Ledbetter, which you would not go outside the bladder to reroute the ureter back into the bladder, but you would accomplish all that intravasically. I've already went through the technical description of that. Again, that's it again for you to grasp the technicality of it. And post-operative, the patient had an uneventful course and went very well. Just discharged after 1 or 2 days, and his follow-up ultrasounds are showing deflated systems upstream. And this is an X-ray showing the ureteric stents in place, and an ultrasound showing what we've just said. So now we come to discussion again with our panelists, and the options that we thought about were reflux. We didn't prefer that because it's very expensive in our setting, and it has debatable, outcome in duplex systems. I would have considered it had it been more available and less expensive for that setting that I did this operation in. Cohen reimplantation was also possible, but I felt it's technically difficult to in a bilateral duplex system to bring them cross over each other, and it attracts all the problems with catheterization of the ureters and access of the ureters subsequently. Heminephrectomy, as Professor Ghoneimi explained, that left-sided kidney wouldn't have tolerated a heminephrectomy, and I felt it's a little bit unjustified because I didn't have a moiety that has lost function to come out. And then, so I went to the common sheath reimplantation in order to preserve the function of all the moieties. So despite it being relatively technically challenging if you compare it to deflux, but I found that to be the best choice, and that's what we delivered. So this is the take-home message: not to assume that there's always a dysplastic moiety in duplex kidneys, although that's the more common finding, and that the functional imaging directs the operation to reconstruct when there's functional preservation. Reconstruction should take precedence over resection whenever possible. A common sheath reimplantation is an effective and protective in bilateral duplex vascular-ureteric reflux, and I really like this modified Politano-Ledbetter technique. I think Alex would agree with me that it's a very nice technique to deliver. Yes, so that was all the information here, and it's open for discussion.
Thank you very much for presenting your technique that well. Amine, would you have treated the kid the same way?
Thank you for this presentation. Thank you, Sabine. I agree with Dr. Marei that I think that deflux treatment will not be efficient for these cases, double system with reflux. It would not be efficient. I will choose to do surgery for this patient. Just I'm wondering about the bilateral Ledbetter. Perhaps we'll have more risks to have like a post-operative neurogenic bladder. But here, Dr. Marei used, modified, Ledbetter without external approach. So perhaps we will prevent this risk. So yes, I agree with the procedure that was done by Dr. Marei, and just I want to have some comments because in some cases we can have like ureterocele, and I wanted here to have like a comment. If you have ureterocele, you know that the puncture is less efficient if you will do endoscopic treatment, and here you will prefer also surgical treatment. And also, Sabine, you already spoke about the heminephrectomy and the risk to have a damage of the lower moiety. And here I wanted to just have a comment that it's very important in case you choose to make heminephrectomy to study with your radiologist, because you can have, aberrant vascularization, and in that case you can damage the lower moiety. So it's very important to to make a radiologic study, very efficient radiologic study before going to the surgery. These are the comments that I wanted to make.
Alaa, please add your opinion.
Yes, as usual, Mahmoud Marei's excellent presentation, like the ones before also, with Alex also. He's always torturing us when we present something with very difficult questions. So now I have to torture him, trying to torture him. So tell me, Mahmoud, you said I agree with you, okay, that you can do reimplantation bilateral. I didn't really understand why a simple Cohen reimplantation for non-dilated ureter is troublesome for this, because it's a very well adapted treatment for this. This is my first question. Second question, I really don't understand why you're putting 4 double G for this, and you are talking about less expensive and surgery. 4 double G is quite an expensive. We need to do second general anesthesia to remove them, and X-ray after. You need to do all of this. Why you are not just draining? If you need drainage, which is it's not really necessary for this patient. If you need drainage, you could put also a ureteral catheters, which is outside with back just for 3 to 4 days, and you don't need it. You don't need routinely to put double G stents. If you don't have tapering, you don't have severely dilated ureters. So that's one thing. Thing, really, I did not understand the modified polytanol technique, honestly, because the hiatus is the same. That's right.
No. Shall I start with answering that bit and then go to the first 2 questions?
Yeah.
Okay. So basically, that is transposing the hiatus more cranially. So after you mobilize the ureter, you would mobilize the mucosa, lift it off the detrusor towards the head side, and then incise the detrusor, and keep doing that until you bring, so you widen the hiatus towards the head side of the patient, and then you close the original hiatus, the detrusor level at the original hiatus, and carry on with that closure on the detrusor until you get until you reach the ureter which you have transposed upwards. So basically, you are transposing the hiatus, you're extending the hiatus cranially, and then repairing the detrusor from caudally towards the head side to leave only a hiatus that fits the ureter more towards the head side. And then that suture line in the detrusor that you have made, that's going to be the backing of the ureter. So you're going to lay the ureter on that suture line, and then you're going to suture the mucosa on top of that. So by doing that, you've achieved a longer tunnel that's in line with the original ureter. I will now come to answering the question of why not do a Cohen. Cohen is a classic technique, but you have 2 ureters on each side, so you need bigger space for them. You need a longer tunnel in order to fit, the combined widths of 2 ureters. So in order to do that, I felt that if I don't have enough widths in the bladder, but I have enough length vertically to create that tunnel. So I would say, I wouldn't say that a Cohen is a wrong thing. I would never say that, but I would say that that's my preference in that particular situation. So in a simplex, I would be more comfortable to do a Cohen. I would be able to keep both ureters. So if I have a bilateral simplex reimplantation, I would be able to keep a distance between both ureters, each coming to the other side. And I would be happier about the relationship between the length and the width of the tunnel.
But the detrosotomy that you did a longitudinal detrosotomy, that's right?
Yes.
Yes. Which means that you just did an Lish Gregoire from endovesical approach.
You can call it that way. I don't think that
you are exactly, that's why in this case, you are increasing more than a normal Leadbetter-Politano the risk for dysfunctioning bladder, because you are doing a bilateral longitudinal detrosotomy. Bilateral detrosotomy, because otherwise, why we did not do just a simple Lish Gregoire for this patient? Extravesical simplified Lish Gregoire, which means just detrosotomy bilateral without opening the bladder at all. It's exactly the same what we have done, but from outside, not from endovesical.
Well, I agree with that point. Yeah, that's point taken. But in my mindset, what causes the bladder dysfunction in the Lish Gregoire is not the upstream incision of the detrusor. It is the mobilization of the ureter at the base of the bladder, where the neurovascular bundle and where the innervation comes into the bladder. So I think that the area where I incise the detrusor is a safe area, and it's not where the innervation of the bladder comes, because that's actually the back of the dome of the bladder, or like we can say the posterior superior surface of the bladder, not the posterior inferior surface of the bladder where the innervation comes from. But I take your point. I might regret that later on, but I have done it in many patients, and I've seen others do it, and it didn't come with that outcome that you are worried about.
I think this is a fantastic discussion, and I believe all of us and all of our audience could probably spend days and weeks discussing this in a lot of detail, and there's probably a lot of different opinions out there, but the most important thing to remember is that there is the risk of dysfunctional bladder if you do a reimplant on both sides, especially if you're cutting the detrusor or coming from behind. So I believe this is one of the most important things to consider when thinking about how to treat those patients. And in the interest of time, because we have already been talking for 1 hour and 45 minutes, I think it is time for a conclusion.
I have one more point to answer to Dr. Ghoneimi, because he asked 3 questions. Why the 4 double J's?
Yeah, the catheters. Okay,
Go
ahead.
I didn't feel comfortable just not draining the left side, which had 15% function. And so I wanted to feel secure about having something that's not going to fall off. And in the setting that I was practicing, I didn't want to rely on anybody looking after those drainage, like sending the parent, the child home with parents, and ask them to look after those ureteric, external drainage catheters that are going to be coming out after a week or after a few days. I just wanted maximum reassurance for that 15% left function. I didn't want edema to cause any obstruction that leads to that kidney taking another hit, because I like symmetry. If I did that on the left side, I felt more comfortable just to have a symmetrical appearance and do that on the right side. So that was all.
Thank you. And I would like to pass on to Muhammad for the short conclusion of this case.
Thank you very much, Sabine. And I think it was a wonderful discussion. And I will just summarize few key points which come across that. If you have a function in lower moiety, you have to consider preserving it. And if the overall renal function is not very good, then going for will compromise the function of the other moiety. So you need to be careful. And one important point was made that you have to invest on a good ultrasonographer to get more clinical information about the renal system, and cystoscopy needs to be considered in selected cases, not in every case for diagnosis because it's an invasive procedure. And I don't see that there was an agreement between the type of reimplantation in this case because both has pros and cons. And at the end, I think it was a wonderful discussion. Thank you very much.
Thank you very much. I think this leads us to the conclusion of this webinar, and I'm passing back to our esteemed chairman.
Okay, thank you to everyone. That was really fantastic webinar. Thank you for contribution. I think there is nothing more to add to talk about any other conclusion. If you have, especially faculty, would you like to say something? Otherwise,
I'd just like to thank
we are
you
going to finish.
I would like just to thank you for this excellent organization and this live discussion and excellent moderation. Thank you very much.
Thank you. Thank you very much for asking us to contribute in this wonderful webinar.
Thank you very much from India also, and wish you all a very good forthcoming Happy New Year, well in advance. We are 1 month short. So have a great time, all of you.
Okay, thank you. Then we can finish, I think. Thanks.
On my behalf, I have to thank all the participants, the group of experts, Professor Ghoneimi, Sabine, Professor Arshad, Professor Miglani, Professor Amine, Ksia, and above all, I have to thank the Turkish Society of Pediatric Urology, my dear friend Baran, Tokar, and Dr. Ihsan Karagoglu, which is doing a lot of job behind us and behind the scenes. And we hope we have reached 181 participant today, and maybe we can promise another symposium in 4 months' time. Thank you for all. It's yours, Baran, please go on.
Okay. So we complete, I think. Thank you. So we can finish.
Thank you. Look forward to meet you again.
Professor Tokar, if you allow me, I'm closing the Zoom meeting. Is it okay?
Yeah, please turn off. Thank you.
Okay. See you. Bye-bye. Good evening to all participants. Bye-bye.